Can I just find out how long you guys have been doing? So who's been doing hearts less than a year? Okay. You're like negative years. Don't worry, you're gonna get to your baseline soon. And then who's been doing less than 5 years? Okay. Anybody more than 5 years? Okay. All right. So this talk is just kind of let you kind of formalize some of the things that we talk about at the bedside to kind of give you our perspective on how we think about heart patients. We have a lot of protocols in place already, but as you can see, not every patient is the same and not every problem is managed the same way, even if you have what looks like very similar numbers. So let's start. What's the most important organ in the body? This isn't a trick, right? Does anybody say anything other than the heart? Okay. Most times when we ask, people will say, they'll mention the brain as the second one. But if we think about it, why is the heart the most important organ in the body?
Because you can live without a brain, but can you live without a heart?
Yeah, exactly, because all the other organs are supplied by the heart, right? There's no organ that cannot live without oxygenated blood. The brain's important. A lot of people mention that because it's important for how our concept of being an intelligent being and interacting. But yes, you could have a live person without with brain death. So if we think about it from an anatomic standpoint, the heart is it's a totally independent organ. It has its own electrical system. So the SA node and the AV node and the pacemaker cell, it does not need a signal from the brain to tell it to work. It tells itself to work. And it feeds itself. The coronary arteries the blood comes from the heart, and those are the first branches off the aorta. So when we are taking care of post-op patients, we always prioritize the heart first. And one thing is that you would think that, okay, we take a patient with any kind of cardiac disease, say coronary disease or a valve problem, we fix a problem. Shouldn't everything be great? Well, there's a number of reasons that's not true necessarily. And the first thing is that the act of the operation is a big physiologic insult to the body and to the heart as well. So I'll go through a few things that happen in the operating room that impact what the patient is like afterwards and why there's so much management. So first of all, what are the two things we do to do a standard open heart operation?
Bypass, cardioplegia.
Bypass and cardioplegia. When we say cardioplegia, what we really mean is we stop the heart. So bypass, what does that mean? Are you like Reese Witherspoon in Elisha? Yeah. So Elizabeth, if you all don't know Miranda's our new NP. And Miranda, what is bypass? What do we mean by bypass?
So basically what you do is you have the heart-lung machine and you bypass. Are you talking about the heart-lung machine? Okay. You take and you cannulize the heart. You basically suck out all the blood into the heart. Goes through the machine oxygenates the heart, takes over your heart and your lung function, and then we return it back.
Right. So basically we're creating a pathway around the heart and the lungs, and the heart and the lungs can't really be separated because they're one unit. And this does a couple things. It decompresses and empties out the heart. And that's useful for doing heart surgery because if, cardiac output is 5 liters a minute. If we're going to open the heart and work on a valve, we can't do that feasibly when there's 5 liters of blood flowing in your face. And so it's necessary to do what we call intracardiac work. Why do we do it for CABGs? Well, it also decompresses the heart. That makes it easier to move the heart around and not have hemodynamic changes. And as far as the oxygen demand of the heart, well, if the heart is empty, even though the electrical system is telling it to pump, it doesn't actually have to pump against a pressure. There's no volume there for it to beat. So that really reduces the myocardial demand of the heart. And it drops to about 2 cc's per kilogram per minute from a baseline. Resting here, we're at about 8. If you were going to run, it would be about 7. Okay. But it doesn't go all the way to 0. However, the fact that you go on bypass means that a lot of processes are kicked off. And these are things that are learned in medical school. I don't necessarily learn it in nursing school, but your complement system gets activated. There's what we call leukocyte activation and all these kinds of things. But at the end of the day, what happens is you have almost like a sepsis type of picture. You get a big capillary leak. So a lot of fluid goes out to the tissues. And that usually persists for about 1 to 2 days, and then it comes back. So there's a lot of fluid status changes. So we're also managing that after heart surgery. So that's cardiopulmonary bypass. The other thing we do is, here we mostly do things on pump and arrested. There are some places that do a lot of out pump cases. We're not that kind of institution, just because of the complexity of the cases and the patients. So why would we stop? Why do we have to stop the heart for certain operations? It is easier, so it's easier to sew these small coronary vessels if the heart is not moving.
Would it decrease the oxygen demand in the heart as well?
Yes, exactly, right? So I said it went from 8 to 1 if you empty the heart, and then if you stop the heart, excuse me, I totally messed that up. Okay, so it goes from 8 to 6 if you empty the heart, and it goes from about 6 to 1 if you stop the heart. Because now that muscle does not have to contract, or the pacemaker cell is telling it to contract. So that really is the main part for reducing the oxygen demand. And then the other thing is, if we're going to work on a valve, especially on the left side, well, if you're going to cut things open, all of a sudden now there's air. Oh, there we go. You're exposing whatever is in the heart to air. Well, you can't have air traveling inside the circulatory system because you have air inputs everywhere, right? So we have to clamp the heart to exclude where you're working from the circulatory system. By clamping the heart, you necessarily stop giving it blood flow through the coronary arteries, right? So that's another reason that we want to stop the heart. It's not getting blood flow, so you don't want it to work. Great. Oh, thank you. So on and so forth, and basically fluid overload. And one of the things we deal with somewhat in the ICU and also largely on the floor is where is that extra fluid? Is it intracardiac? And if there's too much fluid intracardiac, that's heart failure. Is it intravascular, which is where you would like it to be? And if there's too much intravascular, are we diuresing? And is it still in the nerve space? Okay, so we're talking about the heart, the work of the heart. And if you notice here on the box on the left-hand side, 80 to 90% of the oxygen and blood that the heart uses is to this contraction work. And so that's why, here's that picture now. That's why by stopping the heart, which is that little bottom line that I marked with the arrow, that you really reduce your myocardial oxygen. Okay. So here, this is about where we were. Okay, so you see these two wide together cannulas. They're pulling blood from the heart, and you can either put it in the SVC and IVC and capture all the blood before it goes to the heart, or you can stick it straight into the right atrium and drain it right from the right atrium. Okay, goes through the pump, gets oxygenated, gets ventilated, goes through the pump and comes back to the body. And you see that clamp up at the top on the aorta. That's going to separate your circuit, so now you can work inside the heart. And as I said, we then stop the blood flow to the coronary arteries. Well, what does that do? Well, it does a lot of bad things. It flexes cellular metabolism, ion transport, productivity, there's release of free radical oxygen species, et cetera, et cetera. So at the end of the day, ischemia, even though we are protecting the heart with cardioplegia, by giving it blood and nutrients, you do have a period of ischemia even with cardioplegia when you cross. Okay. So how do we give cardioplegia? And this is important because the different routes have their different limitations. And so this is why even if you give optimal cardioplegia, or what you think is enough cardioplegia, there is still some ill effects on the heart. There are two routes to give it. One is what we call antegrade. So how are we going to feed the muscle of the heart, which is what we're trying to protect? Well, you can just use the body's natural system to give it blood, which is the coronary system, right? Okay. So an antegrade cannula goes here in the aortic root. You can see there's a little bit, you can see a little here, the right coronary artery and the left coronary artery. So what happens is we put this here, you put a clamp here, and you give cardioplegia. Well, it can't travel up and away. It has to go down the coronary arteries, okay? And this is, the solution has blood, it has high potassium to make the heart stop, and some other things. The other way to do it is in the retrograde, what we call the coronary sinus. And just to go through this picture, just remember that the arteries, go to the capillaries, go to the veins, back, okay? So when you're putting it in the coronary sinus, it's now going through the veins, capillaries, arteries. And the thing is, it doesn't really matter which way it goes, correct? If you had a UPS driver that had 10 packages to go between St. Louis and KC in a day, as long as he got to all those places, it wouldn't matter which direction he went, right, theoretically. But it would matter if there was traffic or road jam or something along those lines. So when we think about some disease processes that might affect your ability to get cardioplegia, one is, let's say we're there for a CABG. Let's say the LAD is occluded. So if you give antegrade cardioplegia, well, the reason we're there is that the root is messed up. And so it's not going to get very good cardioplegia. So that area of the heart will not be protected that well. The other thing is, I mentioned if you put a clamp here and you're giving that cardioplegia, it should go down the coronaries. Well, if you have wide open AI, it's more likely to go down the path of least resistance, which is going to be straight through that valve, open valve, to the AI, and distend your LV. So sometimes antegrade cardioplegia is not great. What about retrograde cardioplegia? Okay. So retrograde cardioplegia should theoretically doesn't have to go through, it goes through the veins, capillaries, and now can go through their connection to the arteries, right? So it could be able to bypass some of those blockages because it's coming the other way. But there's one major issue, which is that the anatomy of the heart is such that most of the venous system is attached to the coronary sinus. But particularly in the right heart, there are a few veins that drain directly into the right heart. They're not connected to the coronary sinus system, or to that system that collects in the coronary sinus. So if you give retrograde, that area of the heart will not necessarily be protected. And this has been studied, and this bar graph shows you how well different areas of the heart did receive cardioplegia labeled with microspheres. You can see the right ventricle actually did not get very much, and the posterior septum. Why? Because usually that PDA is coming off that right side, right? Okay. So this talk was supposed to be mostly about CABG, so I'm just going to kind of show you. This is a CABG picture. How do we kind of help protect the heart using our techniques? When we give antegrade, we give retrograde. And the first thing we do is start sewing our distal anastomosis. We don't do the proximal first, we do the distal. Why? Because this free piece of vein, once it's hooked up, see here's a blockage, here's where we're going to sew that graft on. Now we can take that free end of the graft and give cardioplegia. So where before the antegrade was going to come down and hit this and not really feed this, now you can use your new anastomosis and feed the heart. And then at the end of the case, hook it up at the top. Does that make sense? Are there any questions so far? No. Okay. So you'll see in a little bit how all this affects our assessment of the patient. So you guys hopefully are familiar with how when we call in or you call us, we always just get the report the same way. Why? So I know there's a culture of don't say that's just because it's always done, but there's a logic to it. So first of all, when you hear us around, there's like a million numbers, right? And how do we process that? Well, if we do it the same way every time, there's an algorithm that helps you filter out the noise. If you do it a different way every time, now two people are trying to get on the same page in the language. So there's a logic to it. And the first two numbers are index and SpO2 if the patient has a SWAN. And we want to know the heart rate and heart rhythm, the blood pressure, CEP and PA pressures, hourly urine output the last 3 hours, chest tube output the last 3 hours if it's the first day or immediate post-op period. And then things like labs, okay? So very standard, and that way if it's 2 in the morning and our brain is fuzzy, we're like, okay, yes, I understand this algorithm, and we know how to process that better. So what are the indicators for the heart? Again, the heart is going to be our number one priority in school if that's working. It's always the cardiac index and the SpO2. Cardiac index above 2 and an SpO2 above 60. Now and then these three things at the bottom tell us how well the heart is working and how is the body working. Now, you notice I grade out heart rate and rhythm and blood pressure. Lately, I've had a number of students that come in and I say, how do we know the heart's doing? And they mention these two parameters. So the important thing to remember is that even though we respond very strongly to blood pressure, it does not necessarily indicate how well the heart is functioning. I'll give you two examples. So this patient, I don't know if any of you had this, he had a TAVR came back from cath lab and was in complete heart block, and his heart rate was in the 40s. But his blood pressure was great, actually it was too much, it was 180 over 90s. So does anybody want to guess, was his cardiac index low, normal, high? What would you guess if you didn't have a swan in this patient? Low, below, anybody normal? Okay, so most people, and in fact, even some other physicians came in and said, oh, we don't need to do anything about the heart block because his good blood pressure is great. Well, we had a swan in this patient, and his index was actually 0.8. Okay, so how do I know that it was that? Well, so then we started transcutaneously pacing him, we gave him atropine, and when his heart rate then became normal, his index actually doubled. So his blood pressure, even though it was high, was really not an indication of the cardiac index, and that's how markedly divorcing he was. Okay, and then the other thing you could do for this patient is an afterload reduction. And we'll talk a little bit about how sometimes blood pressure can be too high for the heart. Okay, here's another example, and you guys probably see this a lot, endocarditis. The fixed valve, they get very septic, and the blood pressure is low, but they have a very high index. And again, the blood pressure doesn't reflect how well the heart's doing because they're septic. They lose their vascular tone. So vascular tone isn't always connected to what the heart is doing. Okay. What about heart rhythm or heart rate? Does that tell you anything about the heart function? Not really. AFib doesn't necessarily mean that there's a low index. It can cause a low index. But if you see VTAC or VFib, especially post-CABG, that's a very serious thing. And it's not so much it tells you about heart function, but it tells you there's ischemia going on. And you need to figure out, did graft go down? Is there an area that couldn't be grafted that is now causing this? Okay. All right, so back to the top two numbers that we always look at, index SpO2. It's greater than 2 and greater than 60, great. Everything's great and we're just going along. If it's less than 2 and less than 60, then it's not great, and we have to figure out what to do about it. Sometimes you have discordance, where the index is greater than 2, but the SpO2 is less than 60, or vice versa. And then that takes a little more work to figure out. One of these numbers is more correct than the other in terms of assessing the heart function. So how do we figure that out? Do you guys have any ideas to start with? What do we do if the numbers are discordant? Sorry, what?
We could recalibrate the
Okay,
SpO2.
so we could recalibrate it. That's true, and it could be just that the SpO2 is not calibrated correctly.
Check hemoglobin.
Hemoglobin. Okay, how does that work?
I mean, if your SpO2 is low, I would want to check your hemoglobin because maybe that a low hemoglobin is why your SpO2 is low.
Right, yeah, so anemia can falsely lower your SpO2. Anything else?
Possibly an ABG just to make sure as far as oxygenation, things are going well there.
Yeah, good. So if your SATs are low, kind of going along with the
Yeah.
anemia, and you don't have that much blood to get, so the SpO2 is going to be low.
CBP related to volume.
Yes, but that's not going to help you so much to figure out which of these is correct.
Oh.
But it does help you in terms of if something is off. If you decide that the one that's worse is correct, you're going to pursue that line of reasoning. Anything else? Okay. So the first thing that was mentioned was recalibrate. We do this a lot, and that's fine as the first step. But what sometimes I see what the night residents do because they don't know what to do is they recalibrate it, and then they recalibrate it, and then they recalibrate it. So that once you get a recal and you see that it's still low, well now you're calibrated. You should be calibrated, right? Unless you move unless the patient moved or the swan moved or something else happened. So recalibrating in and of itself is not a therapy. It's just trying to figure out is my number right or not. It's like when we send a hemoglobin that's low, we want to make sure it wasn't deleted. So you really should only recalibrate once, and then, unless there's some reason to suspect that it got uncalibrated again, not doing that. So we mentioned hypoxia and anemia. Those are good ones. Make sure the swan's in the right place. Actually, there's a patient upstairs right now. Cora called me and she said, "Oh, the index went to 1, but and she's got an X-ray, so it looked like it had maybe moved out. So it could be it could have pulled back into the RV generally. You want to make sure your height and weight are accurate. Remember, the index, the output is what's actually measured by the swan, and then you plug in the numbers for the height and weight to correct for the body surface area. So if either of those is entered in correctly, your index could be inaccurate. TR will can make your index falsely low. Why is that?
Less blood's getting out.
Well, how does a swan work? How does it figure out the cardiac output?
Just maybe by the blood flowing past the thermistor or whatever it's called.
Yeah.
So if you're getting tricuspid regurg, then it's not going to be going to
Yeah.
have
So
blood
what's
flow
that
both ways.
process called? Where
Thermodilution?
thermodilution. So it's measuring the temperature drop, right? The faster it goes, the less the temperature is going to drop, right? But if you have a lot that's going back, now that's going to mix and cause the temperature differential to be different than what it should be. And same thing with shunting, although usually if there's a shunt like a PFO or an ASD, we'll have corrected it in the OR if it was significant enough to cause issues like that. Okay. Any questions on that? We've ruled out all those other things and we've recalibrated and all of that. So now then we start to look at other things because we have to at some point pick the number or figure out which number is really reflective of what's going on in the heart. And so we do things like hourly urine output. We look at an acid-base balance. We look at whether there's a base deficit, and we look at the lactate. Okay. And so we'll use these secondary things and then pick one and go along that strategy. And if then, let's say the urine output drops or your lactate starts to climb, your base deficit gets worse, then you pick the wrong one. You need to more aggressively figure out what is making your cardiac function inadequate. Okay. So, particularly for CABG, you want to maintain adequate tissue oxygenation. That's for all heart cases. You want to make sure that we maintain our coronary perfusion. So, the whole purpose of the heart is to deliver oxygen to the rest of the body. And there's two components of that. One is, do you have the oxygen to deliver, and do you have a good enough delivery system? So you can think of it like Amazon. Do we have the books to deliver, and do we have just a little dolly that some guy's going to run out to like through the neighborhood, or do you have a truck, or do you have a drone system that's going to for the demand of the body? Components of oxygen content: hemoglobin, oxygen saturation, PaO2. So what's the relationship between hemoglobin and oxygen?
That's how your oxygen gets everywhere.
Okay, how?
It piggybacks on the hemoglobin.
Yeah, so hemoglobin binds oxygen. And how many, you guys know how many binding sites there are?
4.
4 binding sites. Okay, and that's the most efficient way. Now, there's also PaO2, which is free hemoglobin just dissolved in the blood. But you can imagine it's like if you're going to ship something, you're going to pack it in the boxes. I think the best. You're not going to throw random boxes everywhere in the truck. Okay? So these are going to be the most important components of your oxygen content. PaO2 is important in the sense because, here, okay. Right. This is the arterial oxygen content equation. So you can see hemoglobin and sat are multiplied by 1.36. So they're pretty important. PaO2, whatever that number is, you're going to reduce it by 0.3%. So that kind of the equation itself shows you how unimportant PaO2 is to the actual oxygen content. If you look at the hemoglobin dissociation curve, it is important because it affects the ability of hemoglobin to bind the oxygen. Where's that inflection point? So this is what we call a sigmoidal curve. You guys are familiar with that? Okay, so it's sigmoidal because it's S-shaped. And the important thing is, above it here, no matter how much you raise this, there's not much, how much you go out further, there's not much increase in the hemoglobin binding, okay? And that inflection point happens at 60. So above 60, you can do whatever you want to drive up your PaO2, but you're not going to get a lot more binding, okay? Why is that important? Well, increasing your PaO2 is cost, right? How do we, if we have a low PaO2 on the vent, what do we do? What are the vent changes you can do?
Increase the P.
Increase the P, and what's the other one?
Increase the
Increase the FiO2, right? And both of those have bad side effects. Your P can cause barotrauma, and your FiO2 is oxygen toxicity, right? So that's when we get a blood gas, and as long as the PaO2 is above 60, 65, well, then we can leave the vent. This is, you're not going to get much more oxygen binding. You're not trying to aim for 100, right? Does that make sense? Okay. So if you have the oxygen content, how's your delivery system do it? That's your cardiac output. Okay, and again, that's the heart. Oh, So what's the equation for cardiac output? If you didn't see that. Heart rate times stroke volume. Right. And a lot of times, it's just heart rate times stroke volume. We also think about heart rate and rhythm. Okay. Heart rate, post-op hearts, we can do a lot more than just like a random patient that came through the ED because we have pacing wires. So we have the ability to manipulate both the rate and the rhythm with pacing wires. And what's the best rhythm to have? Sinus rhythm, right? But let's say your sinus in the 40s, sometimes that's not as good as D-paced in the 80s. So sometimes if we come along and we see a patient who's very slow, that's the pacing and try V-pacing at 80. And there's a trade-off. Why is sinus better than V-pacing?
Atrial kick.
Atrial kick, yeah. So we don't know exactly what percentage that is for each patient. And so we do a little bit of experimenting to see what's better for the patient who's slow. Now why, well, we'll go on. Okay, so then the other component is stroke volume. That's really kind of where all of our skills with fluid status, inotropes come in, things like that. So the three components of stroke volume are preload, afterload, and contractile. Okay, that's going to determine how much your heart can pump out. Anybody know the definition of preload?
The filling pressure, how much it takes.
Okay. So yeah, we refer to it sometimes as the filling pressure. The technical definition is the LV end diastolic fiber length, or LVEP. Now, those are not very practical things to measure, right? So left ventricle, because that's what's the main tumor that we're interested in as far as function. End diastolic, so once it's full. Fiber length, well, you can't measure the fiber length practically, right? You have to stop the heart, cut it out, measure it in a microscope. LVEP, you could estimate by echo, but that's not practical to have someone in the ICU sitting there saying, okay, yeah, that's good volume, no, too much blood, right? So we use our swan to estimate the pressure, and that tells you about where your preload is, okay? If you have a swan, we use the best way is a wedge. We don't wedge here, most places don't wedge just because there are risks to it. So we use our PA diastolic as a filling pressure, okay? So that's important because a lot of times they call, the PA systolic is this. I don't really care that much about the PA systolic or even the mean. I really just care about the PA diastolic because that tells me the filling pressure on the left side. Okay? If you don't have a swan, then you use a CVP. But how do we use a CVP and PA diastolic in conjunction? What tells you which? What tells you what?
So CVP is right, PA is like it's left. So if your CVP is really, really high, if your side, the right side problems.
Yeah. So remember I said that the right heart pumps to the lungs, the left heart pumps to the body. And it's all one organ, but we can think of it over, so you can have right heart failure, you can have left heart failure, you can have both, right? And so we want to really think CVP is reflecting our right heart, PA diastolic is reflecting our left heart, and that can help us diagnose the difference between them. We'll go over that later. Okay. So that's preload, or volume status. Afterload. So afterload is technically LV systolic wall tension. It's determined both by the preload and the systemic vascular resistance. I have to say, practically, we really just think of it as the blood pressure, what the heart has to pump against. So ideally, what would be the least stressful on the heart?
Low SPR.
Yeah, it's afterload of 0, right? So the blood would just go out and we'll be very happy. But that's not good because, well, why is it not good? Why is it not good for the body?
Not going to perfuse anything.
Yeah, you need perfusion pressure to the other organs. And why is it not good for the heart to have that vascular tone? Well, it's not going to go to the coronaries, right? Remember, the coronaries are relying on that pressure to get filled as well. They're like filling. Okay, so we'll go over more the blood pressure and things like that. So contractility, what is the definition is the intrinsic strength of the myocardial contraction. We use ejection fraction, we use stroke volume kind of to think about this. There are a lot of things that can change it. Have you guys heard of the Frank-Starling curve? Okay, anybody want to tell me what that's about?
Stretch and squeeze.
Yeah.
Sort of like the rubber band, if you stretch it out too far, it's obviously not going to pump effectively or stretch effectively and snap back into place.
Yeah. So you think like if you go to the gym, if you use a 2-pound weight, you're not going to get anything out of it. But if you use a 40-pound weight, your workout's also, well, if I took a 40-pound weight and tried to do bicep curls, that would also not work very well, right? Because I would fail pretty quickly. So there's an optimum range of filling of the heart where the contractility itself is going to be best. And that's independent from just your preload stats. Okay,
It's like 3-pound weights.
for you. Okay, so then the other thing is actually the heart rate. You can think of this sort of like gas mileage, okay? Okay, so gas mileage, like your car does best at highway speeds. Above highway speeds, the gas mileage drops, right? In the neighborhood or whatever, suburban settings, it drops as well. So there's an optimum heart rate now. Immediately after surgery, we generally let patients be where they are unless it's affecting the index. In very, very high-risk patients, low EF, we do a big operation, cardiac function is marginal. We usually aim for a pace at 90. So it actually it performs best if it's a little bit faster. In the long-term for coronary bypass patients, we actually want the heart rate to be pretty low because the less times it beats, the less myocardial oxygen demand, right? But in the immediate post-op period, our priority may be contractility of cardiac function. Okay. So sometimes that's why we'll aim people 90, even up to 110. Okay. So contractility also can be affected by acidosis, hypoxia, high PCO2, and medication. So these are other things that there's an opportunity to work on if you have a patient that has marginal cardiac function. Some of this. Okay, so I get this question: where do you want your blood pressure on post-op patients? So what is the ideal blood pressure? Well, it depends, and it's a little bit complicated, but not too complicated. What would you guys say is the usual blood pressure that we're aiming for?
60 to 90?
Yeah, about 60 to 90. That's pretty good. Okay. So what's the problem with too much blood pressure?
Blow a graft. You can blow a graft.
Could be, yeah, okay. Yeah, because the graft is sewn on the aorta. And so if the blood pressure is too high, that suture line can bust open. I have heard of it happening. It's not happened to me yet, but that is a possibility. Also, I just talked about CABG, but diet. Anytime we work on the aorta, sometimes the aorta is very fragile tissue. It tears easily, especially if a patient has just had a dissection. And so sometimes we may be aiming for a lower blood pressure, and we'll generally tell you this patient has bad aorta. Let's keep the blood pressure on the lower side. What's wrong with too little blood pressure? Hyperphagia of the organs. What else?
Losing graft.
Lose a graft, yeah. So consider the grafting organ. So then the graft goes down, and now you have acute ischemia. You're basically giving the patient an MI. Okay. So we get very in the CABG patients, we get very concerned about blood pressure stuff. Okay. And then other. So these are like sort of emergency things right after surgery. So blood pressure control, that's why we want the range we want. What about tachyarrhythmias? Well, in general, so usually you're going to see AFib, RVR. Sometimes we'll see sinus tach. If a patient doesn't have coronary disease, and let's say they were young and came in for endocarditis, that's part of the SIRS response to having their endocarditis operation. And we're less concerned for those patients because they don't have coronary disease. And so their myocardial oxygen demand can be a little bit higher. But in a patient that had a CABG, we really would like to keep that heart rate lower so that this heart, which is compromised, is not needing more oxygen. Bleeding. A lot of issues with bleeding. Do you guys have any questions about bleeding or comments about bleeding? Why does it happen? Okay. Yeah.
I had a question. So DDAVP, when we give that for bleeding, what part are we trying to affect with that? I mean, what does that affect as far as the bleeding goes?
Sure. So that usually improves platelet function. So even though sometimes patients have the enough platelets are not functioning.
Okay.
And this is especially true of patients with renal disease. The other thing is it's not a blood product. It's not like cryo or FMP. So it does save if if it's effective, then you can hopefully save the patient from having blood parts transfused as well. Okay. So sometimes the reasons patients are bleeding after surgery, obviously surgical. We hope that's not the case. If it is, we take it back. And there's a little bit of an art to trying to figure out if that's the case or not. How much time do you have left? But we give them a lot of heparin in the case. We reverse that with protamine and we check our ACT at the end of the case. But sometimes there's heparin lingering. It gets stored in the fat. So sometimes it can come back into the system. And so sometimes you may see an elevated PTT or ACT, even though the OR seemed to correct it. That's another reason. Well, sometimes there's hepatic congestion from being on a pump, or if they had TR or something like that, so your coagulation factors being out of whack. Or could be that they had Plavix pre-op, and so again, even though they have the amount of platelets, platelets are not functional. So that's that. But bleeding is not good, so it obviously, because of the anemia, decreases your oxygen supply, and again, in a CABG patient, especially, you're going to start to have ischemia if your hemoglobin drops too low. It can make you hypertensive. It can make you hypertensive because they've lost that blood volume, or because if you're bleeding inside and it's not coming out the tubes, that can cause tamponade. And so the decision to go take someone back to the OR depends a lot on things that you guys might not be aware of, like what happened in the OR, how much blood product did the patient get, what's their cardiac function, were they on antiplatelet therapy beforehand, and so on and so forth, things like that. Okay. And sometimes we take them back if they've just bled a lot and there's not a surgical site. Let's say usually at about a liter, we take them back because number one, even if it's surgical bleeding, we shouldn't clear anything that's in there because it can eventually cause tamponade. But also at a liter, we probably need to definitely ensure there's no surgical site. Okay. And I've seen all sorts of things. I've seen clips pop off. I've seen a tiny little phrenic artery on that's not anywhere, where our main operation was, but a small vessel that can hide something. Okay. All right, and then so we said generally max 60 to 90. Where do you want to be in that range? Well, if you're bleeding, you want to be on the lower end. But the other thing to think about is even if the heart is happy, we then have to worry about other things. So people that have had a stroke before or have cerebral vascular disease probably want to keep it higher. Elderly people that have had hypertension, or just even younger people that have had hypertension for a long time, their brain and their kidney are used to higher pressures. And so when you put it in what's considered a normal range, to them that may be ischemia, the brain or kidney. So, and then people with peripheral vascular disease, that may, it's a fixed stenosis, so they may not get enough blood flow to the leg. Any questions about that? No. Okay. What about drips after surgery? So are there ways to predict? The first thing I want to tell you guys about this. So this is a tool that you guys are welcome to use. It's called the STS Risk Calculator. You don't need a login or anything, a password. You just go Google STS Risk Calculator. If you guys are interested, you can then, if you have a patient that's going to have surgery or had surgery, you can choose what kind of surgery they had. It doesn't do double valves. It does at most a CABG plus the valve. Okay? And it'll, you enter a lot of variables. I'll show you some of these here. So age, EF, you want your height and weight, what kind of valve disease.
Sorry, I had a question I just thought of regarding the, sometimes you want to increase pressure for people that are used to higher blood pressures that have had, ischemic brain injuries and stuff like that in the past. Is that something that we, how does that get communicated to us where you want the pressure? Like, is that something the resident should know that adjust? Because a lot of times in the orders it's just like 60 to 90. So I don't really know if you want it on the higher side or... Yeah,
usually if we have a concern, we'll be at the bedside and tell you, and we'll also tell the nurses or residents. Now, whether that gets translated into the actual order, I think is something that we can do better at, because especially if the patient comes out like at 5:20 and there's a handoff and then the resident doesn't really get that. So that is something that we need to work on. I would say if they have a history of a stroke, they're elderly, if they have pre-existing CKD, generally we're going to be aiming for higher. And if you see that they're dipping down to the 60s, feel free to clarify with the resident or just call us and say, hey, I think this patient has these risk factors.
Okay.
Okay, so there's a lot of variables to enter. You may not know all of them. Sometimes you can put, unknown or undetermined. But it basically will calculate this risk of mortality, bimorbidity or mortality, length of stay, ventilation, all of that stuff. And this is a tool we use sometimes to figure out if a patient is more suited for a TAVR or a MitraClip than surgery. It's fairly available. Anyways, back to whether we're expecting a patient to be on inotropes after surgery. So some of the pre-op factors, if they have a low EF to begin with, if they've had an acute or recent MI, because again, even though we're going in to fix it, we're then adding ischemia on top of the recent ischemia. And if they have non-viable segments, so sometimes we go in and we do a 3 or 4 or 5 vessel bypass, but we don't always go to the length to get the viability study. Because let's say, for example, Miss Childs. So she had a very bad LAD lesion. If you want to look at her cath, so all the, they shoot the dye and her start goes, and her LAD goes, and it took a long time to fill in. So no matter what, she needed that LAD vascularized. Now, she had OM1 blocked, her stent was included, but her other circ was fine. So we went ahead and grafted that OM1 area, but in her pre-op echo, her lateral wall wasn't moving very well. So I suspect that the OM1 graft is not really helping her that much. And maybe it will recover eventually. Some people, that it recovers immediately. Some people, it takes some time. But if she's on quite a bit of inotrope, and I'm not surprised because these areas probably have some degree of segments of infarct. So if they revascularize, some areas may never work, and her EF may not be well. So that's that. What about factors in the OR? Well, the reason I talked so long about that myocardial protection is if you don't have good myocardial protection. So since she had an occluded right, occluded OM1, that cardioplasia we gave was probably not helping to protect those areas during the operation. And that's an example of diffuse or severe coronary disease, not letting your cardioplasia get to certain segments of the heart. As I mentioned, if you use a lot of retrograde, that's not going to give you good right heart protection. If there's LV hypertrophy, because there's a lot of muscle defeat, and that cardioplasia may not get to all of it. Incomplete revascularization. Sometimes we take a patient in the operating room intending to put a graft somewhere, and we get there, and the vessel's very, very small, or there's no outflow, or sometimes we even plan that we're not going to revascularize this or put a graft here because it's too small. So not all cabbages end up with complete revascularization. Long cross-clamp times, that's just because there's a longer period of ischemia in the heart. Okay, so if we take a patient, let's say a patient with EF of 60, 59, short run, short bypass run, short cross-clamp time, good targets, that patient really shouldn't be on inotropes after surgery. And so if he is, then you have to say, well, what is going on here? Versus the patient like Ms. Childs, who once she was in the OR, the EF was 30, long-standing disease, and targets that were not necessarily going to contribute to her heart function afterwards. Okay, so there's some prediction. What about after surgery? What are things that potentially could be adversely affecting your contractility? I mentioned acidosis, hypoxia, and hypercapnia. So if your vent settings are all messed up, or they've got a pneumonia or something that's not letting them oxygenate or ventilate very well, that can cause right heart strain because the pulmonary vascular resistance then changes and the right heart's trying to pump against something that it's not used to. Again, hypotension can cause ischemia, malperfusion, and risk dropping the graft. And then again, the bleeding issue. So, okay. So if the index is less than 2 and the SpO2 is less than 60, or if it's that discordant one, and we decided that, okay, yes, this patient is not doing well, we need to fix it. Basically, we attack it starting with heart rate and heart rhythm. And we look at the rate, as I mentioned, one is sometimes decide if it's bradycardia. Is it better to be sinus brady, or is it better to be pacing a normal thing? And that's just sort of an experiment. Plug it in, watch the index. Does it go up? Does it go down? Does the blood pressure go up? Or does it stay the same or does it go down? Okay. AFib, you guys, drop in atrial kick, so that's like 10 to 30%. And I would say if a patient is an AFib and their index is really low, and their blood pressure is low, then we just try to cardiovert and not mess with amio. Because amio is going to drop their pressure. Any questions so far? So then the next thing, let's say your heart rhythm, rate and rhythm are optimized, your hemoglobin is optimized, your sats, your PO2 is optimized. Now we attack those things about stroke volume. Preload, we use a CVP and a PA diastolic. If it's low, you give fluid. If it's high, well, what's a normal CVP?
6 to
8.
8 to 12, okay? So if it's low, that's very clear. That's a hypervolemic problem, right? And your heart doesn't have enough to generate the output. Is there a concern? Is it too high? Is there such a thing? Okay, why?
The right heart might not be pumping efficiently for flow.
Yeah, so basically all the volume's sitting here, and that means that it's not going out to the body like it's supposed to. So now you have, what's that diagnosis? Heart failure, right? Okay, and so what's the treatment for heart failure? So it depends a little bit on the immediate post up here. We don't want to diurese, but what you want to do is then increase the contractility, and some of that might be optimizing your heart rate and rhythm. So these things all sort of kind of go in a circle. It's not one linear. Okay. This is a little bit what we talked about. Right atrium, CVP. That's how you know what the right heart fluid status is. PA diastolic tells you your left heart. So let me see. I think we have one case I wanted to kind of highlight. This is 71-year-old man. He had a 3-vessel cabbage and a maze, and then these are his numbers. So someone's okay. So good. So first question. So first of all, dead or alive? So what are the 2 numbers we look at first? Yeah, those suck, right? So this patient's going to be dead very shortly if we don't fix it. Okay. So then the first thing we look at, heart rate and rhythm, right? Okay, so 132. So why is that concerning? Well, he had a maze, so most likely this is AFib RVR, right? Okay. So I would say with this pressure and this index, we're not gonna mess with amio. And we don't, unlike the cardiologist, we don't give metoprolol or diltiazem. Why? Because they're negative inotropes, right? So I would cardiovert this patient.
Because you give him a boatload of peppers in the OR, you don't worry about, and you'd already seen that there's no clots like the day before or something. When you do TEE, you're not worried about cardioverting him?
Yeah, so when we do a maze, we always, it's very rare that we would not ligate the left atrium. If there's a clot, then we will go take out the clot. But you're right, if there's a patient who had AFib, unknown duration, and unknown left atrial appendage status, then you don't want to cover it. Okay. What else? Do you see anything else on the screen that's concerning?
CVP is pretty high.
Pretty high. Okay. What do you think about the CVP relative to the PA pressure?
Your PA diastolic and your CVP are pretty similar, so it just means blood's not really getting pushed too forward.
Yeah, in fact, the CVP is higher than the PA diastolic. That's messed up. It should be the other way around.
So
right?
tamponadicity.
So one thing to be concerned about is a tamponade. And the other thing is if it's not tamponade, then it's severe right heart failure. Because the right heart is so fluid overloaded that it's more overloaded than the left heart, which means that this is severe right heart failure. Okay. So let's say we cardioverted him, we get that. So what's the next move? So we took care of heart rate, heart rhythm. Now we're thinking about stroke volume. So preload, do we have enough preload?
Yes.
Yes, we have too much preload, right? Okay. Afterload is just blood pressure. And yeah. It's okay-ish, yeah. And the main thing is we don't want too high of an afterload, but that's generally not the problem here. So then we would go to contractility. Okay, so that's basically how we make our decisions. Rule out heart rate, heart rhythm, rule out anemia, hypoxia, preload, and then, so then this patient would start, if they're on epi already, would start epi. Now, generally, the course of a patient is coming out of the OR, they're coming off pump, we optimize them in the OR to have an adequate index and SpO2. From there forth, you should be weaning the drips. Now, it could be slow, it could be fast. We set our pace usually at 0.005 to 2 hours for epi. No one will usually buy the daily group. If there's an interruption and you have to go backwards, then you have to say what is wrong. Because generally the hearts should be recovering from the operation. So if you get stuck, then we have to go back to all those things that to start with, figure out, is your SpO2 wrong, is there discordance, is there inconvenience or hypoxia or other things. And then if figured out all those things and things are not matching up, then we get an echo, see if we drop the graft, is there some other problem? And it depends on operational plans. Okay, what questions do you have? Yes?
Why don't we really use SVR here?
I use it sometimes because generally what we're treating is cardiac function, right? SCI, SpO2. If those are adequate and the blood pressure is very low, well, you know it's not cardiogenic, because basically SVR is vasodilation or blood pressure, right? If it's not cardiogenic in nature, then it's usually just a vascular tone issue.
A lot of times when they come back, it seems like I said, they're paced at 90. Their milliamps are set maybe at 20 or even higher. Are you okay with us finding the threshold where that
I would love it
works,
if you guys
or-
did that.
Okay.
It's crazy. Even on the floor, you guys don't go to the floor much. I'll see patient, the wires are out and the box is going. So I'm sure they're burning through batteries. But yeah, because if you can, so what do you use for threshold?
I just mean like sometimes if the pacing wires aren't picking up as well or whatever, you can increase the milliamps and that'll correct the problem. But we don't have a lot of room to go sometimes when it's already at 20.
Yeah. So it depends a little bit on on the position of the heart and all that. So generally, what we do is we find out. So you drop the pacing a little bit at a time, figure out at what milliamps it stops pacing. Then I generally set it at 10 above. Here, I think just by the culture is just set it at 20. Now, the less milliamps you use, the longer the wires will last. So that's why sometimes it's better to just be 10 above the threshold. But sometimes our wires aren't very well placed or whatever, and so even at 20 may not be adequate. And then what we do is switch the A's to the B's, you get to 25.
Okay. Just want to make sure you're okay with us changing that because they didn't know. I have another question. Nobody
Weird.
else have any?
I have one
I know you got to shoot for extubating quickly. I'm assuming there's research or something like there's a good reason for extubating fast. Is there a better recovery to the patient?
Better recovery, fast recovery, less pneumonia, shorter length of stay. And so I didn't talk about it much, but the vent also has effects. It varies. Some patients, the vent has no effect on their hemodynamics. Some patients, because of that positive pressure, it can cause some decreased cardiac function. So that's one of the reasons. Sometimes we'll go through everything and everything's fine, and next to we say extubate and see if that helps. But we should be aiming for what we call fast track extubation. And I wish it would, I feel like fast track, we should just call it normal. Because having a patient on a ventilator a long time you're not really getting that much out of it. As long as they're extubated. What else?
Okay. Why do we focus so much on base deficit, and to correct it, why would we ever do normal saline? Like, how does a base neutral do anything for your base
Good
deficit?
question. So
I know.
so the base deficit, it depends on what's causing it. If the problem is hypophonemia, that's what it is. So let's say you have a base deficit. If the CVP is low, you give volume, right? If CVP is high, then giving volume is not the right thing. In general, if you have an acidosis, you would like to not just give bicarb, because that just sort of it's a band-aid and it'll fix the root problem. But sometimes the acidosis is so severe that you know, like I said, it can impact the contractility, it can impact how well your onion drips are working. Sometimes we will just go ahead and correct that bicarb so that all the other stuff can work. Kind of can get into this cycle where stuff doesn't work, so then it gets worse, and then it smells awful.
So then the saline just kind of like tries to wash out.
No, the saline is to correct hypothermia.
Okay, but not.
Because the base deficit is due to hypothermia.
Yeah.
Okay. But my understanding, you still don't have bicarb in the hospital, or?
I ordered some on eBay.
How much do you pay? I'm trading for a grilled cheese sandwich.
Why?
What else? You want, I talked mostly about coronary insulin. Mitral patients sometimes struggle a lot in the ICU with finding themselves. Why? Okay, so 2 reasons. One is if you have mitral regurg, blood goes backwards to the left atrium and can go out to the aorta. So it's got 2 routes of escape, right? So the LV kind of can get lazy and not be used to having to push all that blood out to the aorta, part of it left to the left atrium, right? So then you fix the mitral valve, and now it has to push all that blood forward instead of some of it passively going backwards. So the LV may be not trained to do that. It's like if you told someone to get off the couch after 6 years of hypertension and running a marathon. So some hearts are quite ready to do that on their own. The other thing is, depending on what you do in the operating room, the aortic valve you can think of as just valve leaflets in general. The mitral valve is more complicated. There's leaflets, there's cords, there's papillary muscle, there's annulus, there's the LV, okay? So it's very much integrated in the LV. In the old days, when they replaced the mitral valve, they would cut out the cords, put the valve in, and expect these leaflets to, and the heart to work the same as it did. Well, when you cut the cords, this is that weird picture. When you cut the cords, the heart loses its shape, its natural shape, which is an elliptical shape, and it kind of dilates out like this. And so you don't have that attachment up there anymore. And so the heart doesn't work as well. It's not designed to be like that. So this is a study that showed the pinker the people that they save the cords, and the ejection fraction really didn't change much. The blue lines are the ones where they cut the cords, so the ejection fraction drops a lot because the heart now is not really designed to be that molecular shape. Okay. Anything else? Yes.
I don't see that we use albumin a lot if somebody is hypovolemic. You know, if what's the rationale, or am I wrong, or
No, I think it's just surgeon preference. There's not necessarily good evidence of that. Some places use albumin. It can, I think it does tend to leak back into the third space more, and then so you can have more fluid below pulmonary edema that you do. So that's it. I would say that's why I do it. I don't think there's any randomized studies between versus other.
Why do we use fentanyl as our main IV pain medication of choice, just with a short half-life? I guess I feel like it's just a lot of times you're reaching that hour and you're still needing more pain medication with fentanyl. Is there a certain rationale with fentanyl versus other pain medication, or is it just short half-life?
Not really. Again, I think just sort of preference. I think it is a little bit better in the elderly. I think, in my experience, I don't know if you guys have, morphine seems to work better in young people, fentanyl better in older people, and you have to have older people. I think also the short half-life, because you worry sometimes about the effects on the blood pressure. Anything else? Okay. Thank you.
Thank you so much.
Email me or
No
call me.
clap, or is there clap? There's clap.